what we used to study was like, you do an ultrasound, you do a Sestamibi, and then, if there is some discordance, then you do a 4D CT. Right? So when are we doing a 4D CT now?
I think the best person to answer.
Well, see, in the workup of a parathyroid adenoma, they do ultrasound first, of course, and then if it is suggestive, then they send to us for a Sestamibi scan. 4D CT is basically for anatomical localization. Sometimes if it is required,
Very
but nowadays they use it very rarely, and in our department we do a CT scan as well in Sestamibi SPECT CT, and with the PET CT, F-choline PET CT, we do
that covers up the
so
CT
it covers
part.
up both.
So,
yeah, both the functional and anatomical, we are able to do this sitting, the scan in the same sitting. So I think the trend is shifting now, and in our hospital at least they have now shifted to F-choline scan, and our endocrinology is also sitting here, and they send to us for F-choline scan more often now. Though the cost is obviously a practical issue, but
that's where Komal comes in, because in a public hospital you need to look at that aspect also, and you can be selective about it. So it's not done as a routine, Komal. I would be happy with a good ultrasound localization rates are 80 to 85%, and that's usually good. It's not too bad. And like Dr. Paul was mentioning, intraoperative ultrasound is brilliant if you know how to do it. It is picked up. Somehow we don't have a system of because I was doing the previous place, we were doing our own ultrasounds. So it's easier to find even a mediastinal node, a mediastinal parathyroid. Yes,
So sometimes we have got 40 CT done when we are able to find out on Sestamibi, but not on the ultrasound.
Yes, we had.
And so sometimes we have gone reverse also, and we have told the ultrasoundologist, we have found this on Sestamibi, can you repeat it? And so in one patient you operated, and so we are able to find out on ultrasound later on. And one patient we are not able to see on ultrasound, but we found on Sestamibi, then we got 40 CT. Because sir, from endocrinologist point of view, or maybe from surgeon also, we like to get two investigations. One is anatomical, one is functional. So it's always better.
Brilliantly answered. For the benefit of students, anatomical and one
functional.
Is the functional. So, like they have the PET RACIST criteria for assessing response to therapy these days, anatomy, tumor shrinks, but many times the tumor doesn't shrink, but there is nothing inside, it's dead already. So they use both, the functional part of it as well as the anatomical part of it. Yes, please.
Yes, as sir is rightly said, in fact, in Sestamibi we don't have the facility of doing a contrast CT, and the machines, obviously PET is more superior as to SPECT. So with the F-choline PET CT coming up, we are able to cover both.
So how much does it cost, by the way? Because
cost is about 24,000, sir.
That's an issue. But then we develop adenomas elsewhere.
This is cheaper here. Sir, we got last week only I got a patient from
cheaper, and they are very accommodative. We are able to get it done in most cases. But don't carry home, the academic question was brought up by Komal, as she rightly mentioned. You need to be choosy about it. Not everybody should get it, and we don't get it done every day.
So actually, we have seen a patient last week only. He was very PET calling outside, and somebody was charging 70,000. So he came to me. She must have gone to her last week only. He said, just go and ask the rate here. Maybe.
No, it's a very, very. There is nothing we can't say more
about. Sir, if we get ultrasound system, maybe we don't get choline, sir. If there is some discordance, then we can get only.
See, I worked with a gentleman in UK. He said, I am happy with only ultrasound. He's so good at his own ultrasound. So he would do thyroid, parathyroid scans all himself. But it is very much operator dependent. Who is doing it is important, and on whom he is doing is also important. So it is not one answer, one statement for all that you can work.
So just, somewhat related, somewhat not related. What was the calcium? Was she on any calcium supplements in the post-op period, or was she eukαλcemic,
that you talking in terms of total thyroidectomy? No, normocalcemic, as far as the latest records are concerned.
So this patient? This patient, she came to me in OPD. Initially, her calcium was from 12.2, it was 10.8 or something.
No, Ajay, she's asking about when for a total thyroidectomy happened.
So whether she had permanent hypoparathyroidism in that?
She couldn't have lived with that for so long with the kind of supplements. So obviously she must have had a transient hypocalcemia at that time, which must have got sorted, And that is where the suspicion would come of autotransplantation. See, the autotransplantation is done in two situations. One is you have any parathyroid which is going wonky, you will autotransplant to be on the safer side. We don't leave it there, and all black is not dead and all chirpy is not living. So we make sure that it's not dusky at the end of it. The probe test is negative, everything is done. Autotransplantation can still be done. So this one freak thought that came to mind was somebody did it as a part of the procedure. The second thing is what Japanese practice in total thyroidectomy for cancer. They take out all the parathyroids first. I've seen it, that's why I'm sharing with you. They take out all the parathyroids first and they mince it like, and actually I learned from them. My video is there on the YouTube where autotransplantation is shown. Exactly their technique. They mince it so well, very thin slices, and then they autotransplant after they've cleared all the nodes. So that's being too radical. So we do whenever it is there. So these thoughts are